Hi, my name is Dr. Harim Jaffer. I'm periodontist. Today I'm talking about dental calculus. Please subscribe to my channel HL Challenge. My lesson profile is regarding the role of dental calculus. We may discuss supragingival and subgingival calculus in the form of comparison, the composition of calculus, attachment to the tooth surface, and the formation of calculus, the etiological and clinical significance of the calculus. And we also talk about some other topics briefly, very briefly, which are materia alba, food debris, and dental stain. So, starting from the comparison between the two types of calculus which we have. So we have supragingival and subgingival calculus. Regarding the location, the supragingival calculus are located above the gingival margin, while the subgingival one is below the gingival margin. The color of the subgingival calculus is brown or greenish black, while the supragingival calculus white, yellow in color. They derived from salivary secretion. Most of the supragingival calculus are derived from saliva, while the subgingival calculus derived from gingival crevicular fluid. Composition in the supragingival one, there's more bruchite, that's say more of phosphate, and octacalcium phosphate, but there's less magnesium. While in subgingival one, there's less bruchite and less phosphorus and octacalcium phosphate, but more magnesium. In the supragingival calculus, salivary proteins are present, while in subgingival one, they are absent. Also, here's the sodium content is lesser than the subgingival calculus because it's increase with the increase of the depth of the pocket. So we mentioned the color. Regarding the shape, in the supragingival one we have amorphous, bulky, gross deposits. It's usually of irregular shape. It takes the shape of the surface that it forms on. But we may find the subgingival calculus more in a flattened form because it has a pressure from the wall of the pocket because it's found subgingivally. Regarding the consistency and texture, the supragingival calculus, they are moderately hard, newer deposits, less dense and hard and porous. The surface covered with non-mineralized plaque. While the subgingival one, it's covered with the plaque and it's brittle, but it's difficult to be removed actually, the subgingival one. While regarding the size and quantity, the quantity of supragingival calculus depends on the personal oral hygiene care and physical character of the diet, also individual tendencies, function and uses, as well as the use of tobacco and smoking. While in case of subgingival calculus, it relates to the pocket depth, and it will increase with the increasing of age, because subgingival calculus is primarily related to the development and progression of periodontal disease. As more as we have pocket, we have more subgingival deposits. So the sources of mineral, mainly supragingival calculus, is from saliva, while subgingival calculus from inflammatory exudates which came out from or found inside the gingival crevicular fluid. This is regarding the comparison between the supra and subgingival calculus. The composition, we have two main components of the dental calculus, which was inorganic and organic components. The majority is inorganic component, which are about 70 to 90%, while organic component is 20 to 30%. For example, in the organic portion we have calcium phosphate, calcium carbonate, traces of magnesium and other metals, while the organic contents consist of proteins, polysaccharide complexes, dead cells, leukocytes, and various types of microorganisms. And the carbohydrate, which is related to the organic content, is 1.9%, and 9.1% of the organic components consist of galactose, glucose, mannose, glucuronic acid, and galactosamine, and etc. So carbohydrate comprises 1.9% of the organic content, and 9.1% of it consists of these elements. We have the attachment of calculus. We have 4 types of attachment. The attachment, for example, in the first one, by means of organic pellicles on the surface. This is enamel. This is pellicles, salivary pellicles. The calculus, one of them is attached to the pellicle, then to the cementum. This is cementum. Well, the second one, the second type of attachment, we have mechanical attachment between the calculus and the enamel. Like you see it here, this is the calculus and this is enamel. This is to the organic pellicle, then to cementum. This is directly to the enamel. Of course, this is supragingival calculus. We have another one when we have, for example, close adaptation on the cementum. We have here intact cementum without irregularities, with slight sloping, and the calculus is directly attached to it. And also we have mechanical locking to surface irregularities. This is cementum, this layer, and that one. And we have this disruption or irregularities on the surface of the cementum, which the calculus is attached to it. This is regarding the attachment, the ways of attachment of calculus to the tooth surface. We have formation of calculus. We should know that calculus is a mineralized dental plaque. And the soft plaque is hardened by the precipitation of mineral salt, which usually starts between the 1st and 14th day of plaque formation. Calcification has been reported to occur in as little as 4 to 8 hours. And calcifying plaques may become 50% mineralized in 2 days and 60 to 90% mineralized in 12 days. All plaque doesn't necessarily undergo calcification. So we have a plaque that's calculus former, or a person that's a calculus former, and other one have a plaque but non-calculus former. Early plaque contains a small amount of inorganic material, which increases as the plaque develop into calculus. Plaque that doesn't develop into calculus reach a plateau of maximal mineral content within 2 days. The plaque contains maximum amount of calculus within 2 days, and despite that, it doesn't undergo calcification and formation of calculus. And also we should know that microorganisms are not always essential in calculus formation, because we have research that we may find a calculus occur readily in germ-free rodents. So the bacteria, it's not necessary to be present inside the calculus. Saliva is the source of mineralization of supragingival calculus, whereas the serum, transudate, and gingival crevicular fluid nourishes the minerals for subgingival calculus. We talked about that the sources are different. The calcium concentration in a plug is 2 to 20 times that found in saliva. Early plug of heavy calculus formers, the early plugs of who develops calculus, contains more calcium, 3 times more phosphorus, and less potassium than that of non-calculus former, suggesting that phosphorus may be a critical than calcium in plug mineralization. So phosphorus is, we thought that calculus is the main element for plug mineralization, but phosphorus is the main element. So this is regarding the formation of the calculus. So we have plug matrix, which act as a seeding agent, and there will be an induction of formation of small foci of calcification inside the plug, and these foci will enlarge and it will adhere to each another. Then it will form a calcified mass. Then it will be more organized in a form of calculus. So this is regarding the formation of the calculus. About the etiological significance, there are positive correlation between the presence of calculus and the presence of gingivitis, but this correlation is not as important as between the plug and gingivitis. This means that gingivitis, the main causative factor of periodontal disease, is a plug, but calculus not act as a causative factor. It is just act as an aggravating factor or risk factors. Subgingival calculus is a product rather than a cause, because plug initiates gingival inflammation, which leads to pocket formation, and the pocket in turn provides a shelter area for plug and bacterial accumulation. The increased flow of gingival crevicular fluid associated with gingival inflammation provides the minerals and mineralize the continually forming plug, resulting in subgingival calculus formation. So it is not a cause, it's a product. It's the process when the plug accumulates subgingivally and the inflammatory exudates come into it and nourish it with minerals, then it will be calcified and forming a risk factor rather than a causative factor. The importance of the danger of calculus regarding the periodontal disease acts by making the biofilm, it makes the plug, dental plug, the biofilm of bacteria in close contact with gingival tissue, because it has a rough surface and the bacteria will aggregate on the plug retentive areas. Also retaining the biofilm or the plug and providing inaccessibility to remove the plaque properly, and that's why it will enhance the progression of the disease. So this is also calculus formation. We have another terms regarding materia alba, food debris, and stain. MFS, material alba, food debris, and stain. Regarding materia alba, it's a loosely adherent mass of bacteria and cellular debris that frequently occur on top of dental biofilm. When you don't clean the plaque, a loose, whitish, foamy, or sometimes cotton-like pieces of bacteria and food debris accumulate on the surface of the plaque, and it's clearly visible without disclosing tablet, and can be removed with the water spray and oral irrigator, whereas the plaque can't be removed. So that's the difference between the plaque and materia alba. Food debris is rapidly liquefied by bacterial enzyme and cleared from the oral cavity by salivary flow and the mechanical action of tongue, cheeks, and lips. And the rates of clearance from the oral cavity varies with the type of food and individuals. Aqueous solution are typically cleared within 15 minutes, whereas sticky foods may adhere for more than 1 hour. We should know that the dental plaque is not a derivative of food debris, nor is food debris an important cause of gingivitis. Regarding the dental stain, we should know about dental stain that they are pigmented deposits on the tooth surface. Primarily, they have an aesthetic issue and do not cause inflammation of gingiva. The use of tobacco products, coffee, tea, and certain mouth rinses and pigments in food can contribute to stain formation. This is the end of my topic for today, which was about dental calculus. I hope you enjoy it and follow me on my YouTube channel. Thank you for listening. Have a nice day.